Welcome back to session 3, where we are exploring how digital tools can support safe and appropriate use of medicines in older people. Of course, transitions of care are a crucial juncture in a patient's journey, and paying attention to medicines at these points in time is really important. Natalie Kawaji is here to tell us more about the medication management at transitions of care stewardship framework.
Hi everyone, I'm Natalie Kawaji, a Senior Project Officer in the Digital Health team at the Australian Commission on Safety and Quality in Healthcare. Today I'll be introducing the Commission's Medication Management at Transitions of Care Stewardship Framework. Transitions of care is when a person's healthcare is transferred between care providers. Transitions of care are at risk of incomplete information transfer, miscommunication between clinicians, and delays to accessing medicines. In fact, more than 50% of medication errors occur at transitions of care. In Australia alone, medication-related errors lead to over 250,000 hospital admissions annually, costing our healthcare system an estimated $1.4 billion. And so there is a heightened risk to patient safety at transitions of care, particularly for older people who may have complex comorbidities and are on multiple medications. This emphasizes the need for effective care coordination during care transitions, including the importance of clear responsibility and accountability for a patient's care between health professionals and across organizations. The Commission's Principles of Safe and High-Quality Transitions of Care, which were published earlier this year, highlight the need for multidisciplinary collaboration and coordination that relies on shared responsibility and accountability between clinicians. Australia's response to the World Health Organization's Global Patient Safety Challenge, Medication Without Harm, which you would have heard about earlier today from my colleague Steve, highlights that establishing and implementing medication documentation and communication standards across all transitions of care can lead to reductions in medication errors and adverse drug events. Embedding digitally mature health infrastructure and systems can enhance good communication between clinicians, ensuring that transitions of care are as seamless as possible. Now, whilst this may be complex, we believe it could be best achieved through a stewardship approach. And so the Commission has developed a Medication Management at Transitions of Care Stewardship Framework, or as we would like to refer to it, MMAT-TOC. Stewardship Framework, based on findings from a literature review and an environmental scan, which are now summarised in 2 reports that are published on the Commission's website that I encourage everyone to check out. Existing stewardship frameworks and programs such as antimicrobial stewardship, expert advice from a dedicated project advisory group, and feedback received from a targeted consultation with internal and external stakeholders and a public consultation that only recently closed. The framework aims to support coordinated governance of medication management at transitions of care, or MMAT-TOC, promote and optimise appropriate MMAT-TOC, reduce hospital readmission rates due to medication errors that occur at discharge, and improve hospital referral pathways to primary and community healthcare providers for safer MMAT-TOC. Essentially, it is a systematic approach to coordinate activities and interventions that aim to optimise medicine's use for all patients, including older people at care transitions. So what does it look like? As you can see from this figure, there are 4 key elements that make up this framework. Element 1, structure and governance. Element 2, multidisciplinary stewardship team. Element 3, activities to support safer MMAT-TOC. And Element 4, ongoing monitoring, evaluation and reporting. In addition to these 4 core elements, the framework highlights digital health as a key enabler to achieve interoperable, accurate and timely bidirectional communication between clinicians in the acute and primary and aged care settings. This is because digital enablement is increasingly recognised for enhancing MMAT-TOC and overcoming causes of missing or inaccurate information and communication breakdowns. There are several digital initiatives that are aimed at enhancing safety and quality, including for MMAT-TOC. For example, secure messaging, which supports the exchange of clinical documents amongst clinicians. The National Health Provider Service Directory, which supports electronic communication between health providers and message delivery. My Health Record, which connects allied health providers, including community pharmacies, to electronic health records to provide them access to health information that they may not otherwise receive. But we know that variability in digital health maturity exists across Australia. And so the Medication Management at Transitions of Care Stewardship framework can be implemented locally by health service organisations who have different digital solution capabilities. The framework is designed to help health service organisations build, implement, and improve local MMATOC stewardship, which of course should be tailored to the local context based on a risk assessment approach and a priority needs basis. So what do the 4 elements that I mentioned earlier include? Element 1, structure and governance, describes the establishment of effective governance processes for local MMATOC stewardship. This includes having clearly defined roles, responsibilities, and accountability for stewardship, having executive buy-in and sponsorship, including the necessary resources to support MMATOC stewardship, developing local policies and procedures that provide guidance on local MMATOC stewardship implementation, and ensuring that there is a stewardship committee within an organisation's committee structure to direct and support MMATOC stewardship and to oversee its effective implementation and ongoing function. Element 2 describes the formation of a dedicated multidisciplinary stewardship team that is responsible for the coordination, implementation, and sustainability, as well as championing of local MMATOC stewardship. Regular engagement with internal and external stakeholders and representatives from other care settings, for example, primary care, is also very important, as this will facilitate multidisciplinary input to enable coordinated approach for medication management at transitions of care. This will also improve collaborative planning and decision-making. Element 3 describes evidence-based, person-centred stewardship activities that health organisations can implement or improve across a patient's hospital journey. For example, medication reconciliation on admission and at discharge, risk stratification on admission and throughout admission to select priority patients who are at a higher risk of medication-related harm during transitions of care, and medication-related hospital readmissions, as this can enable targeted interventions that may lead to reductions in readmission rates, particularly for more vulnerable populations such as older people. Partnered pharmacists' medication charting where legislated, provision of the discharge summary to the GP, and uploading this to the My Health record. The framework also promotes early communication between the hospital team and the patient's GP, especially for those patients who are identified as being at higher risk of medication-related harm or readmissions. This is so that they can discuss the fact that these patients are high risk and to collaborate as part of early discharge planning on which medication management services would be most appropriate and beneficial for these patients to receive post-discharge. For example, home medicines reviews and residential medication management reviews that we know are severely underutilised. Not only does this aim to facilitate effective clinical handover and bidirectional communication between these clinicians early, it also supports timely GP coordination and follow-up of these services with their patients post-discharge as part of ongoing continuity of care. Element 4 is all about ongoing monitoring, evaluation, and reporting. It is essential for health organisations to routinely measure the performance of their local MMATOC stewardship implementation, and this should be against predetermined quality indicators. Results should be regularly reported to the local governing committee to trend improvements. So where to next? Our team is currently reviewing all the expert input and feedback that we've received on the framework from the public consultation. Following this, we anticipate to officially launch the Medication Management at Transitions of Care Stewardship Framework in early 2025. This framework will be the first national framework that aims to support medication management at transitions of care to enhance patient safety and care. So be sure to watch this space. Thank you.
Thanks, Natalie. Digital systems can be important tools, or they can be written off by clinicians and languish. How can we predict how these tools will be used and set them up for success? Here's Professor Melissa Baysari to share her insights.
Okay, so today I'll be talking about human factors and digital health. I thought I should start off with a definition of human factors. This is a commonly used term, but often misunderstood. It's not factors related to people like communication and decision making. It's actually a scientific discipline, the study of work. Another word for ergonomics, but those of us that don't work in the physical ergonomic space usually avoid that term, as people often think of chairs and desks. So it's the discipline that applies evidence-based methods and knowledge about people to design and improve the interaction between people, systems, and organisations. And the overall goal of human factors is optimal system performance. So we want people to be highly productive in their workplace, make few errors, and also be happy. So we want humans to be happy and productive, satisfied in their workplaces. How does human factors actually do this? Well, it's all about good work design. We design and redesign work systems in order to optimize the interaction between people and other parts of the work system. So things like tools and tasks and their environments. So here is SEIPS, which is one of our most commonly used human factors models. And you can see there that the person is at the center, but the person is interacting with many other elements of the work system. So that they're performing tasks, using tools and technologies within an internal environment, within an organisation, and in an external environment. And in human factors, we're interested in all these elements of the work system as well as the interactions between them. So the person interacting with the internal environment and their tools and technologies, for example. So if we have a good fit between people and other elements of the work system, then we get good patient outcomes, as well as employee and organisational outcomes. So for this presentation, I was asked to discuss what factors influence clinicians' acceptance and use of digital systems to support the safe use of medicines. And I've been working in this space for about 15 years and can say that acceptance and use is dependent on multiple factors. The technology is really just one part of the wider work system, and it's only one component. In my opinion, I think it's the human technology fit that's actually the hardest part to get right. So I'm just going to share with you some examples from my research where the end users are talking about problems with the technology. And I think the end users have a lot to say about technology design. So here are some examples. This clinician said, the tricky thing with alerts is there's definitely that sense of alert fatigue where you're just like, oh, I'm sick of this, so close. Nah, I'm not even following you out of spite. Another clinician indicates that the technology is hard to find. I think firstly because you have to click through so many things to get to it, like sometimes I sort of want to do it, but then it takes so long that you just don't have time. And another clinician talking about the text, so it's just a paragraph of writing. I don't think it sends a very strong message. Some digital technologies also require users to hold too much in working memory. So this clinician says there's no save button. It's hard for you to go and look at what you need to see on the medication chart and come back. You're kind of forced to address everything on this one screen. And a huge problem that we've seen emerge with electronic systems is the problem of defaults. So keep your eye out for defaults. This doctor said if a doctor prescribes an antibiotic at 8 o'clock in the morning, the system defaults the antibiotic to be given at midday. Now, for a patient with severe infection, they needed the antibiotic to be given immediately. This is not an ideal situation where they can't wait for another 4 hours before receiving their drugs. So there are some examples of users discussing problems with the technology, but speaking to end users can also reveal a lot about the human technology task fit. And I'm going to provide a couple of examples here as well. So here's a junior doctor that said, I wouldn't use it because usually the person who's actually doing the prescribing is the boss who's saying, I want this, so you do it. In this case, the decision support is not being used by junior doctors because the decision support's not targeting the decision maker. This doctor said, I have to admit on a ward round, I'd probably be reading 10% of all alerts that come up because there's so many. And sometimes there's the same ones over and over. So there's just no time when you're in a rush ward round to actually read the alerts. So this quote is indicating that alerts are not being read because they're not useful in this particular context. This doctor said, because we're already prescribing VTE prophylaxis and the tool I thought was for hospital funding. So in this case, the VTE risk assessment tool was not used because it was not perceived as being useful, and users obviously had a poor understanding of its purpose. I'm pretty sure the VTE risk assessment tool has a greater purpose than hospital funding. And this senior doctor said the decision to prescribe something is based on your clinical knowledge. By the time you type it in and prescribe it, you've already made that decision. So in this case, the medication warnings were ignored because the decision support actually triggered at the wrong time. And finally, this doctor said, I haven't been taught how to use them. I just press the prescribe button. And here they're referring to order sentences, and order sentences not being used because of inadequate training. So this last example I think is interesting because it highlights that the technology is not the whole story. So there are things surrounding the technology implementation which are also really important. And research has shown that the same system can be perceived differently by different users. The same system can be used differently by different users in different contexts. And the same system can produce different outcomes in different contexts. So I'm just going to end with one example of this. So this was work undertaken by my PhD student, Bethany Van Dort, and she looked at in-depth antimicrobial stewardship teams and how they worked, and was particularly interested in how technologies supported AMS work. And this study was undertaken at 2 hospitals in the same district who used exactly the same technologies and had the same technologies in place to support AMS. And what she found was at Hospital A, the antimicrobial stewardship dashboard was used to identify, filter and review antimicrobials, to identify and review patients, to review antimicrobial histories, and to support the AMS meetings. At Hospital B, the AMS dashboard was rarely used. Staff didn't see a need for it, and some of the staff in the AMS team were even unaware that it existed. So this example indicates one of our main consequences of poorly designed and poorly implemented digital systems. And that's the first one here on this list, low uptake of systems. So if a system is not well designed or implemented, you're likely to get low uptake of the system by end users. But there are also many other unintended consequences of poorly designed and implemented systems, including frustration and annoyance, workarounds, so people working around the technology, as well as new types of errors. And how do we minimize these unintended consequences? Well, in my view, I think we should be taking a human-centered approach. This is not so surprising, but we need to understand the users of the technologies, and we absolutely need to understand the context of use. We also should be designing for work as done, not work as imagined. So many of us imagine how work is being done based on a policy or a procedure or a guideline, but in reality, work is not being done in that way. So we should be understanding how work is actually done in practice. And thirdly, we should be designing for a problem. Let's not implement for the sake of implementation. And I think this is definitely a key issue when it comes to technology, people implementing technology for the sake of technology. And finally, and I hope all my quotes illustrated this, we should be involving end users from the beginning to the end in terms of design and implementation of our systems. Thanks for listening.
Thanks, Melissa. So what kinds of digital tools are on offer? Here's Michael Backer.
Hello, my name is Michael Backer, and I'm the Chief Pharmacy Information Officer for SA Pharmacy in SA Health. Additionally, I'm a PhD candidate with the Digital Health Research Lab based at Flinders University. My subject today is to talk to you about managing medicine safety using digital tools in rural and remote settings. Our challenges in healthcare are not ostensibly engineering ones, meaning that some technology constraint is not stopping us from achieving our objectives to reduce health record segmentation, to improve the utility of our tools, and to reduce the amount of attention and effort required to undertake the processes related to healthcare delivery. Instead, these are supply and translation problems. It's an ability to see the development and then the continued use of the platforms to bring value to our workforce involved in healthcare delivery that is the biggest barrier to these systems existing. Like it or not, our health system is not integrated. Instead, we use interoperability concepts to exchange limited subsets of information between health records. What we would ideally like to have is that we have a health record that continues with the patient, much like what they do in between different physical encounters with healthcare providers. So instead of having to have a hospital record that is separate to one in a community pharmacy or GP surgery, is that that record would go with the patient and be modified by the GP, community pharmacy, and hospital as they move through the healthcare system. But instead, as I mentioned, we're using interoperability concepts to send information, albeit with some manual processes often still involved, to exchange a small amount of that. But we do not have a single contiguous record. The problems here, we're going to use a specific example to analyse. Through the use case of medicines reconciliation and review, we will highlight the problems with the current design of our healthcare infrastructure, our digital health infrastructure rather. In South Australia, hospital pharmacy staff deliver more than 70,000 medication history and reconciliation processes to patients admitted to hospital per year. Little to no tools exist to support the identification of patients that would benefit from that process. Similarly, there are no tools that help to identify patients during their hospital admission that require additional review. Many of the tasks and processes that we undertake in this medicines reconciliation review are quite manual. So although the process is very valuable, we undertake onerous searches across digital health records to reconcile medicines information manually and to identify the valuable improvements to care. These are very repetitive and onerous processes to administer. Unfortunately, we repeat this process at every encounter, at every transition of care, and there is little gain with seeing patients of a complex need regularly. AutoMedic is a project that is in development through the Medical Research Future Fund as a collaboration between the Flinders University Digital Health Research Lab and SA Pharmacy. What you see on your screen now is like any other electronic medical record or EMR. It's been designed intentionally to be that way. But in addition to the standard information that you see about a patient, there are also flags that relate to the importance and urgency of reviewing that patient that are underpinned through sophisticated algorithms that have been informed by clinicians in their expert areas. AutoMedic has undergone a thorough co-design process of more than hundreds of hours of putting clinicians in the room addressing the pain points of what they find related to the workflows being undertaken in hospitals and in electronic medical records that they use. The impact of this tool is really around process redesign. So what we know is that our systems are segmented. We have quite a wealth of information that sits in a patient's My Health record that is manually searched and then reconciled through human processes with the hospital EMR to identify discontinuity in medicines for that patient. Through some very simple narrative redesign, we can present that information back to people and really ease the burden of undertaking that work. So what you see on your screen here is a prospective reconciliation of medicines against the patient record with the hospital EMR. So we can see the regular dispensing and prescribing records for this patient that have happened in community and see that there's some alerts that are related to the presence or absence of that medicine in the patient's hospital record. So we're being instructive to the clinicians that are using this as to where their alert needs to be. In terms of process, AutoMedic is undergoing a pilot trial in 2025 and then moving into a randomised control trial that will really establish the benefits of what this has to do. So from a simple process like narrative redesign and presenting information in a usable format through to identifying and then specifying important scenarios, we can instruct users in the process of, while they're interacting with their patient, what it is that they need to focus their attention of. So rather than having to go through a process of searching and identifying, then retaining what the elements are related to the patient care that need to be addressed across the thousands of other tasks that they're working on, we can help to filter that down to things that are pre-programmed into there and informed by clinicians. As with most digital health interventions, the key is designing this in a way that works for our clinicians and that puts consumers in the middle of this process as well, addressing what the pain points are related to the existing systems and ensuring that they are fit for purpose and will scale across care settings as well. To the next part, which is related to consumer-facing and consumer-driven, tens of thousands, again in South Australia, but across Australia, of patients leaving a hospital receive a medicines list. For most patients, this is in a paper printed format. So although that is created using a digital system, we then go and print it and hand it over to the patient and their carers, where we rely on them handing that through to other healthcare providers that they interact with. To redesign that process, the intent here is to create a tool that can be shared with the patient, but actually puts them at the centre of their care, so that rather than the medicine list being created by a hospital and then being handed to a patient, the medicines list is tied to the patient record in Automedic, and they can share that with other healthcare providers, allowing them to either view or edit their record as they see fit, creating an opportunity to have that verified by community pharmacists or GPs prior to coming into hospital. And again, having this cascading impact of being able to make the effort required to undertake reconciliation review considerably easier for our patients, and ultimately improving the level of patient care that we're able to deliver with less human effort required too. Automedic is an example of an intermediary that sits between our hospital record systems and My Health Records for patients. It's a tool that can potentially scale. So through the RCT that Automedic will be going through, what we'll be identifying is, through engagement with our healthcare providers, the key criteria that need to be there to try and prevent preventable medication-related harm. Once that's been validated, we're able to scale that across settings, whether that is something that works from our metropolitan hospitals going into our more regional and remote settings where GPs may be even more time poor than what our metro hospital clinicians are, and helping them to be identify the criteria with which their patients need to be reviewed. Or perhaps even aged care, where the emergence of EMRs has really accelerated in recent years, but again, the human attention element is still quite a constraint to delivering high quality care. In addition to that, Automedic and tools like it may be better fits for workflows, because these have been built around co-designed processes with clinicians that address their clinical workflows and also the pain points of current EMRs. We take all the good things and we're able to reinterpret all the pain points to try and enhance our workflows and the efficiency of undertaking tasks. Ideally, we're supporting workflows and the process of making decisions rather than trying to interrupt or correct them later on. And the third tenet of tools like this is patient engagement, where we really reorient and put the patient at the centre of how these tools will work, so that we ensure that they follow them throughout their records and that we avoid the further containerisation of that information across different segmented systems. By creating the foundation for tools like this, it also opens up to the emerging field of social prescribing and digital health interventions being prescribed in the community to help benefit patients. We know that there is a large adoption of digital health related elements in patients, whether we're driving that from healthcare or through the development of smart devices. So there's clearly an appetite there, and we just need to build that backbone for these types of systems to leverage off. If you would like to know more about Automedic, understanding that it is going through a trial and randomised controlled trial next year and into 2026, you're welcome to contact Professor Niranjan Bidagadi, who is the lead of the Digital Health Research Lab at Flinders University, or you can also get in contact with me as a PhD candidate related to the lab and the Chief Pharmacy Information Officer and Clinical Lead for Automedic in South Australia. Thank you very much for your time.
Thanks, Michael. And we'll actually hear more from Michael and Melissa in our panel discussion in just a moment. But first, how can the uptake of digital tools in general practice be improved? Let's hear from Alice Nugent about her experience in Aboriginal community-controlled health services.
Hi, my name's Alice Nugent. I'm a pharmacist with the National Aboriginal Community Controlled Health Organisation. I'm here to talk to you today about digital tools used for medication management in Aboriginal Community Controlled Health Organisations and share some of the stories of how these tools can be used to optimise medications management in any health service across Australia. I will begin today by sharing a couple of stories of where we've seen some of these digital tools working well in some of the Aboriginal health services where I'm honoured to work. And that includes in the lands of the Thubbagar people of the Wiradjuri Nation in Western New South Wales. And I'd like to pay my respects to elders past, present and emerging of all the lands across Australia where we're meeting on today, and to extend that welcome to any Aboriginal and Torres Strait Islander people who might be joining us today. I'd like to acknowledge the Aboriginal and Torres Strait Islander people are the first medicines experts of this country. So I'll begin by sharing a bit of a story about one of the health services that I've been honoured to work at. It's in a large regional town, and we're lucky enough to have a lot of different prescribers in the service. The town has lots of different pharmacies, so the clients have a great choice about where they want to go. But unfortunately, we were hit hard in the early waves of COVID with some fairly tragic local deaths in early days. So we suddenly had to go from, offering transport and all sorts of coordinated services to overnight offering telehealth services only. And to help support the prescribers with this, we were able to stand up electronic prescriptions very quickly within the software, and using that for all of our prescription generation from that point. This was able to save reception staff and everybody else a lot of face-to-face contact and a lot of time from running around and chasing those pieces of paper. The best pharmacies that we worked with are also very proactive in enrolling particularly our dose administration aid patients for an active script list. So this saves the patients from having to chase tokens, relying on mobile phones and emails. That we tend to set it up as directly going to the pharmacy email as the best way to manage things. And using that active script list to pull down the prescriptions as needed for dispensing to fill those dose administration aids. The best pharmacies are also able to then close that loop of communication by generating an automatic upload of what's going in that dose administration aid and sharing that through the pharmacist shared medication list, which puts that complete record of what's in that blister pack straight up into My Health record, so that can be pulled down no matter which setting the patients are then needing to access that information. So it helps people in the hospital setting to know what people are taking, or if they move around different prescribers or different specialists and other health services, if they can go in and actually have a look at it. Unfortunately, that automatic upload of the dose administration aid option through the PSML is only currently available through the Webster software at this stage. So expanding on this case study, some of the digital tools that enable this workflow to work well is when the prescribers can generate electronic prescriptions whenever they're requested from the pharmacy or during the consults, and if that default is set to the pharmacy email, and obviously that requires patient consent and enrolment in the active script list. A bit of a barrier there is we do then still need to generate a referral letter to go to the pharmacy to advise them about those changes to the dose administration aid, because otherwise they may not be aware which medications are ceased if they're just working off a new prescription. So it's important then that patients are put at the centre of this process, and that they're then flagged for education regarding any changes to those dose administration aids, so that education can be provided at the time of collection. It's really great when everybody does have access to this accurate record of information of what's in the dose administration aid. And what's even better is when it's kept up to date and the information is also there regarding non-packed medications such as inhalers and over-the-counter medicines. Where it's been able to work well in this particular location is when there has been a stable and well-networked local workforce. So a great example of where these digital tools work well is in our diabetes clinic, which we run in the service fortnightly. It's a space where patients are comfortable. We can offer transport if we need to. We have an endocrinologist dials in over telehealth. You can have a practice nurse or Aboriginal health worker sitting in with the patient to advocate for them. The diabetes educators there on the day to provide extra education if needed, literally showing people videos on the screen of how their devices might work. Then we can case conference it at the end of the day to make sure everybody gets paid, follow up on the paperwork, sending any letters about any medication changes or other referrals, hopefully all going through seamlessly through a secure messaging service embedded in the software. And overall, then patients get their medications quicker and feel more comfortable and better supported. Unfortunately, that's not what always happens. So everyone wants to hear a disaster story. Sometimes we fall at the first hurdle, and locums aren't even set up to do electronic scripts in the software. Sometimes we have no idea about changes that happen from specialists because they're still doing paper prescriptions and sending a letter that might arrive a week or two later if we're lucky. Sometimes you get patients that go to the pharmacy and they're don't have embedded electronic script workflows well set up and literally still print electronic prescriptions onto a piece of paper, and that repeat then gets lost to the system. We have patients who just don't quite trust the whole electronic setup. They have difficulties managing tokens. Not sure if you're all aware that you actually need to have credit on your phone to be able to access the internet, to be able to pull down your tokens. So that's why using the active script list model is a lot better. What else can go wrong? It's difficult when we get multiple prescriptions generated, when you have restricted PBS authorities, so then people are going through too many meds in the month. And we also need to consider what happens when electronic prescriptions are cancelled. This can be awesome when we have an issue flagged through real-time prescription monitoring, such as overuse of opioids or pregabalin. We can cancel that remaining repeats on any of those prescriptions and then trigger the patient to come back and actually have a discussion about safe management of their medicines. But this can be a real pain in the bum for patients and really take away autonomy when it's managing something as simple as, say, a step up, step down inhaler program or like a COPD or asthma action plan, when patients really should have the autonomy and be empowered to make their own choice to access their own prescriptions if that script has been cancelled. So I'd like to summarise today by pointing out some of the gaps in the system. Unfortunately, for anyone in remote areas using the RAS S100 scheme, this information is just not going up to My Health Record because of the way that system's set up, that the data's not dispensed in real time. So we really need to make sure that we bring along all patients in all settings across Australia, and if people can actually work with our sector to make sure that it is a genuinely patient-centric model where we can iron out some of these gaps and help support patients through the journey, then we can make sure that everybody has access to the best health they can and help use some of these digital tools to close the gap. Thank you.
Thanks so much, Alice. So let's unpack some of these ideas a bit further. Joining me are Professor Melissa Baysari, Professor of Health Research at the University of Sydney, Mr. Michael Bakker, Chief Pharmacy Information Officer in South Australia, well, he's here at the moment, and Ms. Kate Oliver, Program Manager of Digital Health at the Australian Commission on Safety and Quality in Healthcare. Welcome to all of you. So Mel, before we saw you share some anecdotes that were really relatable for anyone who's used any kind of digital system imposed on them by work before, what sits behind these sort of the commonalities, I suppose, here?
I think a general theme across all the research I've ever done is surprising lack of involvement of end users in the design and implementation of these systems. which is, surprises me a little bit, because I think there's a lot of value in involving end users from the start to the end. So unfortunately, I think we need more of that in healthcare. I think a lot of people feel like these systems are imposed on them from either senior staff, management, the hospital, exec, wherever it is they're working. So I think if there was more clinician involvement in the design, in the selection, in understanding what systems are needing, what problems are need to be solved with technology, then I think people would probably have more ownership of the technology, accept the technology more, use the technology more, and we'd have better design systems.
Yeah, that sense of like knowing what the problem is you're trying to solve, Michael, is something that you've spoken about.
Yeah, absolutely. And sticking to scope with that as well. Like, so often you start on a project and then see that scope changes as people just begin discussing it, is that can be useful in sometimes, but it also can mean that you end up taking on far more than you sought to do initially when you began looking at a problem.
Right. And so, Kate, one of the places where these sorts of systems have so much potential is in transitions of care, but because it's such a critical moment, there's risk there as well.
Yeah, absolutely there is, and that's why it's really key to have great communication. It's great to have those tools and opportunities of using our electronic medication management systems and our electronic health records, etc., to support great communication. But it's also really important, therefore, to have that clinician involvement, have that face-to-face, so that there can be iterations on what's gone before and improvements to make those really key, important changes where they're needed.
Yeah. And I suppose like the theme of today is quality use of medicines in an ageing population. Like, that's really the focus here. What are some of the key opportunities, Kate, for helping this work with digital systems?
I think people really need to get involved, which is sort of what we were talking a bit before. That's really where it starts. So looking for those opportunities to do a course or even get involved at ground level where there's opportunities out there for them, and then to build on those skills and play a part in how those systems roll out and improvements to them.
So Mel, from a health practitioner point of view, what would you like to see people coming to digital tools? What sort of mindset would you like to see them coming to digital tools with?
I think people should be positive about it because they generate lots of opportunities, but at the same time, I think we need to keep in mind that the technology is just one part of a larger system. There are lots of things surrounding the technology which would be required to support the use of that technology. And following on from what Kate said, I really think technology are tools that support work. They're not the main solution, and we should be thinking about the capabilities and limitations of the users of these technologies. So in bringing in clinicians understanding their capabilities and limitations, what tasks the technology should support. I think we should be thinking a lot about task-based kind of support. And if we're designing technologies for consumers, then it's understanding the capabilities and limitations of the consumers as well. And they've got very different capabilities and limitations than our healthcare providers.
Knowing that there's those other sort of supports in place, so like looking at clinical governance and the systems in place. The Commission's doing some work around medications, medication management and transitions of care, and using digital tools around that. And I guess one of the key founding pillars of that is having those structures and governance in place so that those the technology can flow from that, and knowing that those supports are there. So that's one of the key pieces.
Talk to me about what those underpinnings look like, because I think that's really invisible work, but it's so crucial to these systems actually working.
From kind of like a semantics level, right, is that we're defining ways in various other parts of the Australian Digital Health Agency and other groups looking at the kind of semantic interoperability, right? So that means how can two different systems talk the same language so that you can actually exchange this in a way that when I send it across to you, it means that you receive it knowing it that is the context of that information that I've sent. Now that's important, it's really crucial, but what we're not seeing is the development in the market of the tools that actually utilise those to do that work. So although we have those concepts, we have the secure messaging allowing delivery of referrals from a community setting into hospital for discharge summaries going from hospital straight to GPs or into a patient's My Health record. Those are very valuable, but we also need to see the emergence of these tools that help do the blending of the actual workflows, and Mel's area that she's talking about there that help to address this unmet need in the processes that we need to undertake that still remain in healthcare delivery, whether that's decision making or just doing tasks too.
Well, you sort of mentioned that before in your presentation, this sense that for me as a patient, I'm in a health setting and I'm just trundling through. For the health setting, it's very modular. There isn't often that feeling of a continuum.
Yeah, absolutely. So the patient, the physical person, continues, right? But you just have this stack of paperwork either in an electronic format, which is really more accessible but not any better in terms of navigating, whether we hand that to a patient as a set of papers that they can access digitally or physically, doesn't really change that it's very difficult to navigate. What we've seen starting to work over the last couple of years in the US is that you're putting the patient at the centre of that. So when you discharge from hospital, a patient is able to access a subset of that hospital record. They're actually prompted to convey that information to their family practitioner. So if you're coming home from hospital, you might get prompts that say, hey, Michael, while you were in hospital, you had some high blood glucose levels. Would you like us to convey that across to your GP? If you say yes, then when you go and see your GP next, they're actually prompted to say, hey, when Michael was in hospital recently, they had this pathology result. Would you like to take action on it? Would you like to send that away for 30 days or just do nothing with it? It becomes quite instructive and in the process of making decisions as opposed to trying to correct them when someone's taken a path that kind of doesn't meet either protocols or standards of practice.
I'm thinking about our context as an ageing population and medicines are complex, as a consumer especially. Does it rely on a certain level of health literacy from the consumer to be able to interact with a system like that?
Yes, definitely. And digital health literacy, so health literacy and digital health literacy. So I often think about how many people are aware of like the limitations of our technologies, limitations of other technologies like social media and all these. So I think we need health literacy, but also digital health literacy in our consumers. Yeah.
And they're often leading us in ways, especially in the public sector of healthcare. We're quite far behind in many different areas of where consumers are saying they want us. The adoption of wearable devices related to sleep, the utilisation, like you just look at the growth of different technologies that consumers adopt, like ChatGPT or any other large language model. The time that it takes them to reach 1 million users now can be measured in hours, whereas it used to take weeks or months or years to do. So we're trying to play catch up actually in many ways, although we need to have the design principles in there and the derivatives that relate to like how we actually put a system together based on best practice. They're kind of telling us, meet us here, because we're already there in lots of ways.
Okay.
I was just going to say those structures and governance again. So, having good information to source from is really important in all this. So, having, in terms of national digital infrastructure and things, putting together, the provider kind of lists and things and having those available, and all of those sort of elements are foundational to making this really work and seamless.
It adds the responsibility element to it. Like as soon as you start to get into those really highfalutin areas like AI, is that clinical governance layer is the thing that's protecting someone from doing something that might have quite a big impact. Like if you rely on traditional technologies, one person doing one thing affects one patient. You stuff up something with an AI model, the scale of impact can be much higher. So although you can get benefit, the risk also proportionally increases.
Absolutely.
I am keen to talk about AI because I think that that's where people's minds go now that is the new technology that's emerging, and perhaps it could solve all our problems, perhaps it could cause new problems. Michael, what do we know about how AI systems interact with the way healthcare systems currently work?
So what we know is that they're like good at hyper-specialisation, right? So when we look at some of the tools that have been either successful or unsuccessful, is that there's a lot that are failing to translate out of the lab. So we can get them to do one thing really well, but the realities of healthcare delivery is that when you have a clinician working across a spectrum of different tasks and they start trying to use a tool that's really good at diagnosing a fracture in the femur of a patient, and all of a sudden they're taking image of multiple bones, it's not going to work as well. And so what we see is that tools that are, by all conventional benchmarks, highly precise, highly accurate, are failing to fit into practice where people are deciding between tasks or moving between them rather than hyper-specialising within one. So the kind of thing that we're learning there is that sometimes new isn't always better, but also that we need to have benchmarks for our tools that are anchored in real world scenarios and not just sensitivity and traditional benchmarking validations for AI models.
Mel?
And I think some of the more challenging aspects of AI are not really the back end and the technology parts, but the interaction between people and the technology and how AI is actually used in practice. So I think we have a lot more work to do on that end, and I think there's been a lot of focus on the back end and not enough on the human-computer interaction end.
So what would that look like?
So I think we can take a lot from other industries who have battled with AI for many years, 40 or 50 years. I mean, obviously, healthcare is unique in many respects, but at the same time, I think we can definitely take some lessons from mining and banking and defence and transport that have been using automation for many years and have tried to minimise the risks associated with the use of that. So I'll just give an example. A common one is skill loss. So if you use a technology for a while, you're not required to do things in a manual way anymore, and so then you often forget how to do something because the AI is doing that thing for you.
How is the Commission sort of integrating these sorts of perspectives?
Well, recently, I guess we've just put out a literature review around AI, and we're looking at developing resources for clinicians and those in the hospital settings and others to understand more about AI and how it can be introduced and utilised safely. I guess that's where we're working with other sort of organisations and agencies as well to bring that to life at this moment in time.
I mean, there's so many industries. Mel mentioned before transport, and I think in the innovation space, people really look to startups and the space race. For some reason, we're obsessed with it. Michael, what can we draw from those that can help inform us here?
There's two sayings that I like. One is that your capabilities drive your requirements. So often it is that a group in a corporate governance or clinical governance role will sit back and go, we need to do something in AI. Everybody's doing something in there, but actually you can't get there until you know the fundamentals when you're talking about data elements, the quality of data, the workflow processes that contribute to the development or existence of that data and the information that you can glean from that is really crucial. And then the other one that I really love is that you can't get to the moon by climbing increasingly tall trees, right? At some point, you need to redesign the processes that you're using. And that's really where we get the benefit from digital health systems, is that it's not the competition for who's going to do a task. It's more like, if we can build a system in a way that meets what the user's requirements are, we can eliminate the need for a task to happen altogether. And that's when you really start to be giving time back to people to do the things that people are best to do, which is really important. Again, like what Mel was saying, is that these lessons that we can take from other industries who have taken this path before us, these like human-computer interactions, when there's a term in machine learning of human in the loop that's existed since the early to late 70s type thing. Machine learning is not new. It's something that's existed for a long time, and we can pick and choose from the way that other people have gone through their process with this to try and miss the wrong turns that we could take in healthcare where we make mistakes that end in patient harm. But we can optimise the way that we do this so that we avoid those wrong turns and don't take as long to get there as well.
Follow on from Michael's comment, I think one of the challenging things is kind of designing for current workflows to ensure that everything aligns, but then also innovating and changing the way we have done things for many years because it might be more efficient or better or safer or. And that's why I grapple with this as a HF person, a human factors person, because our principle of good design is consistency. So ensure that it's consistent with the way things have always been done and people pick it up really quickly. You don't have to retrain them because it aligns with what they've done before. It's interesting. It's kind of like there are some things I think we really need to break away from and try new things. But at the same time, we've got to probably take it step by step so that we don't,
Not everything is a new idea, and you can iterate on it where it's beneficial to do so. But sometimes you just have genuinely new ideas that shake things up too.
And so being able to do it in a safe and managed way and having those supports around is very important when you're introducing these new technologies. Yeah.
If I can expand on something specific there, there's emerging frameworks around the implementation of AI models and doing that in a safe way. So one that's getting a lot of traction is the Salient framework. The idea there is that you don't just go and turn this machine over to all of your data and say, have at it and start making recommendations to me. it's really a stepwise process from the development to mapping the clinical workflows that you hope to impact, understanding the data elements that you're working with, and actually like a shadow silent deployment of it. So if we're talking about like a clinical decision support tool, that could be in the form of users are doing their normal work, and it isn't until they've done that work that they actually get the feedback to them of this is what the machine thought that the suggested path was, and the discrepancy between what they undertook as an expert, already an established expert in the field, versus what the model was suggesting. If that's close, that's the ideal, but what you can also then open up to is these unique human feedback loops that then go to the safety and monitoring of the tool, continuing to watch that emergence of bias and drift that happens in machine learning as well. So there's a lot that we can take. Again, these are things that are being used in other industries. It's not all just machine learning, is that there's more advanced techniques like machine teaching and active learning that kind of give you a warm start to that's really important to things.
I'm really interested to talk about an individual clinician and their ability to be part of this conversation, because a lot of this is quite high level. It's like, how do we design systems? How do we choose and implement them? Super important. But for the majority of people today, they're in a system. They often feel like passengers, unwilling passengers in a system. How do we give them a sense of not just a sense of agency, how do we give them agency?
I think some would prefer not, and some would. So I think it's very individual. I think some clinicians are happy to just go along the journey, don't want to make decisions, don't want to be involved in those types of decisions. And then others, I think, are much more, empowered, really want to innovate, want to be involved in co-design, want to try new things. So I do think we shouldn't kind of, as a general rule, assume that everyone wants to do that. I think we have, like our digital health education needs to improve a little bit. I think we have a lot of our workforce who are also a little bit not very confident in using technologies or not well-versed in co-design, implementation, these kinds of concepts. So I think there's also a role for universities to play in ensuring that people, all our health professionals, as they leave, have some digital health knowledge, basic level at least, and then we should be offering opportunities for those who want to pursue and go further, potentially careers in these areas, opportunities to do that. Yeah.
Okay.
I think that, these would be Mel's words as well from her talk earlier, is like co-design processes are so crucial to this, is that, so many of our conversations about improving systems are predicated on an EMR that probably came from North America, and that, mostly probably start around finance systems and encounters of patients and being able to record those for billing purposes. You then start just bolting on more and more clinical features, but they're just kind of adjustments as you go. Whereas sometimes it's appropriate to just rebuild things from the ground up with the consumer, with the health clinician and the workflows, the journey that they're on as the basis for it. So I think that, my hope over the next few years or decade is what we'll see is that we start to see tools that are built for the purposes of the people that are using them. If I go into my shed, I don't just have one tool that does everything in my garden. I have a hammer for this task, a spanner for that task. The incentives that we have here are very different to other parts of the world with, the government pays for most of all of our stuff, basically. So most of the development and seed funding for all of these things comes from a research framework. So evaluation is really important. So not to underplay the importance of how crucial that is. We don't want people just licensing up tools that actually have no value or anything. So you need a really robust evaluation framework. So for in Australia, a lot of the things, Automedic, the tool that I spoke about today, is from the Medical Research Future Fund grant. There's other grants out there. Not everything costs a multi-million-dollar grant to get going. We don't have to have everything be at the top end of that requirement. But there's not a whole heap of different mechanisms for genuine kind of research and development in the digital health space in Australia.
It is perhaps, at a local level, talking with others about what is and what isn't working, and then looking at ways at escalating or sort of uplifting those messages, and from that way people can become more involved. It's taking that interest and looking for, okay, but what's really going on here? And is this actually working? Like, we're in this workflow here and I'm not sure that, it's actually working for us. So it's building on that interest, perhaps that discomfort, and taking the next step.
How do you foster those sorts of conversations?
Yeah, it's a really good point. I mean, I think there's lots of opportunities. It's talking to your colleagues in an informal way. It's talking to perhaps managers and others in your organisations in a more formal manner, perhaps. And it's making those connections, I think that's really where the need is fostered.
Potentially you're providing opportunities like kind of in an automatic way. I remember reading some papers once about people could, in their electronic medical record, provide comments about whether this alert was useful or not useful for them and providing comments. So, and then people were entering feedback, and then the IT group would review the feedback and go, hang on, everyone seems to be hating this alert. Let's have a think about whether this alert is really needed. So if there are mechanisms that can be, I mean, I think people are passive because their comments go nowhere. So we should be using people's comments and people's feedback. And if we can in some way incorporate that as part of clinical care and work, I think that would be amazing.
How often is the saying, the straw that broke the camel's back? But realistically, it's the ton of weight that they were carrying beforehand. And there's some really valuable emerging evidence coming out about digital health stresses, and actually going so far as to say how that contributes to burnout and people leaving the healthcare workforce altogether. So we have this obligation to do something about it, because it's not only is activity demand increasing, our patients are more complex, but our healthcare workforce is either not growing, can't grow, or will take too long to grow to meet that demand. That we have to be able to try and make some inroads here, appreciating that the way that we do things at the moment is actually burning people out quite a bit too.
It's wild that these tools are making people be more overworked and leave when they're really meant to be doing the opposite.
Right, exactly. And it goes back to one of those earlier questions that you had, is about what do we put the value on when we're evaluating what we should be doing. Is that we quite rightly respond to big events, these sentinel events. You have to do something about them, absolutely. But how many times do we try and shave, minutes off a process that happens hundreds of thousands of times in our healthcare service that affects nurses, doctors, pharmacists? Is that, proportionally changing tasks that have a really frequent, often occurrence can do so much to benefit your healthcare workers and the essential tasks that they have to do in caring for patients, whether it's charting medicines or logging back into an EMR to equip medicines. If we can make these things 10, 20, 30 seconds faster, is that adds up. In South Australia alone, we have, I think it's more than 4 million medication orders that are charted a year, just in one state. So that process takes a couple of minutes for each order, kind of on average. Some medicines are harder to chart than what other ones are. But 4 million is a lot when you start to do this stuff at scale. So if you can even shrink that by 10%, you're talking about a lot of person hours that are returned back to people to engage with patients, to find the problems that are there that they need to find, that only they can at the moment, and to really give back to a group that, are clearly burning out because of where our technology is at the moment.
Safe technology, usable technology. We should be getting the benefits we expect from technology: safety, efficiency. I think at the moment we're probably achieving more in safety, not so much in efficiency. And I can understand there's a bit of a trade-off there. If you're going to be safe and thorough, you might need to be a little bit less efficient because you need to complete more data and enter more data in. So, I think what we expect from technology, we're not achieving the full potential. So I hope that we will.
Is it about better data and utilising the data that we have in a better way? I guess that's the real...
That's a good suggestion.
Yeah.
Michael?
Nothing really to add there. There's a lot of work, as Mel, I think, rightly points out. Safety, it is a very real thing. It's kind of how healthcare is different to these other industries, is how much that governs the way that we make decisions. And we've got to hold ourselves accountable in our structures to make sure that we are doing that, absolutely. But we also need to give stuff back to our staff, because if we're putting something on that will take a few extra seconds, and it happens a lot, we're taking something away from what they're otherwise doing in their role as well. There is no kind of, we have to be able to reconcile that and identify it too from the outset. So I think it's important that we have these initiatives that actually there's safety and quality, they're efficient, they're better quality care than what we can deliver, but we've got the processes in place to monitor them too, that we're getting what we need, so that if it goes rogue, we know before the event's happened. And that doesn't have to just be an AI thing. That could just be, how many clicks does it take to do a process? What are we actually measuring the changes that we are implementing by.
For people who are listening who maybe are not in charge of designing or purchasing systems, but they're in systems, what's something that you hope they can kind of take away from this and be like, I can be an active participant in this system, I can be part of the change here, that doesn't involve maybe leaving pharmacy and going to work in health policy instead, like the two people sitting to my right here. Mel, where would you start?
Speak up would be my advice.
Mm-hmm.
Yeah, so you don't have, everyone I think thinks they have to put up with it, but they don't have to put up with it. If everyone speaks up, changes will be made.
Okay.
Yeah.
Well.
Yeah, I think people vote with their feet, right? That doesn't mean you have to be part of an evaluation panel or anything like that, selecting a piece of technology. It's very much like what are people asking for is typically what services give them in terms of improvement requests. So it's about being vocal and also having the mechanisms to catch it too. You don't want people becoming apathetic towards change, not feeling like they can't be effective. So organisations have to be able to catch these things and say, well, we couldn't do that before, but maybe we can now. Maybe things have changed.
Okay.
And there's lots of changes occurring in terms of more information's coming out, more standardisation of processes to support safety. So referring back again to the medication management at transitions of care, putting in place the structures and governance, having the teams to be able to talk about what's going on, making sure that those medication management activities are in train, and then that monitoring thing and having all of those sorts of aspects in train really helps to bring people on board and bring people on the journey and make improvements where it matters.
And so a lot of the participants at today's symposium have submitted questions, and one of the big themes that's come through is a question around how health practitioners can leverage digital tools to support medication management specifically.
Yeah, so I think we're seeing some of those, like Automedic, there's the parent program for that one, CareMapper, which has a mental health use case, is that not all medication errors are the same, right? And so if someone is not charted for a blood pressure medicine that has a really long duration of action, we don't need to rush to actually responding to that in the same way that someone who is missing their clozapine, that if we don't actually get that restarted for them, they may have to spend quite a number of weeks in hospital being retitrated onto that. So the way that we build our tools and the focus on that really needs to be informed by, we're seeing this with how we've done clinical decision support previously, where we get alert fatigue. You don't have to work in healthcare to know about pop-up fatigue. It happens everywhere. So it needs to be salient. It really needs to be important to the task that you're trying to undertake and the cohort of patients, because what the subspecialties care about in one area may be different to what you're looking at with a focus on in your patients in another subspecialty. So we kind of need this curated ability, and that when people have said, I don't really mind about this interaction, it may be clinically appropriate, we don't continue to flash it up to them to say, hey, this is really important, you need to respond to this, when actually that may be part of the normal patient care. And so there's this element of adaptivity that needs to be there in how we build out our systems that's really core to this designing it with clinicians, for clinicians, and working across that fit for purpose element. And so that we can get the kind of scale. We might start with experts that are in a hospital metro setting, but the most value in this tool may be actually about not taking it from the experts, and you give it to the junior clinicians where they're still needing that knowledge growth. You give it to the regional and remote hospitals that are serviced by GPs, where they're already competing across 1,000 different tasks that you're helping to direct them as to where their attention needs to be. You're not trying to do things for them, but you're making the processes that they already have to undertake a bit easier, and recognising medication-related errors that could contribute to preventable medication-related harm. That's where the real value that keeps these things going comes into it.
Okay.
That's right. Yeah, and the Commission has lots of resources around medication reconciliation too, and electronic medication management. We have our implementation guide for EMM, which is a really useful resource, and it's very useful to go back to and reflect on how have we implemented, and is it really working for us at the moment, and what could we potentially, elevate or potentially change. Where are we at with that? We also have an electronic medication management self-assessment tool, which is really helpful to understand the structure of your system and whether, all of the quality use of medicine principles are really there and are playing through the whole workflows for medicines. We also have a whole range of medication reconciliation tools which are also available. So really ensuring that you've got the best possible medication histories there to then make further decisions on for all the patients. So really recommend that people take on those resources and really use them to their full capacity to support patient safety and further quality. Yeah.
Did Kate just mention your favourite document ever?
My favourite commission document is the EMM guide. It's fantastic. I highly recommend it. But to Michael's point, I completely agree. I think there are lots of, we've overdone decision support for medication safety. We need to take a step back. What are our key problems that we need to be focusing on when it comes to decision support and design of our systems? So let's take a very problem-focused perspective. I think moving forward, we really need to be doing that.
Such an exciting frontier. Thank you all so much for sharing your insights.
Pleasure.
Yeah.
Thank you.
Thank you very much.
I would now like to welcome Professor Christine Kilpatrick AO, Chair of the Board of the Australian Commission on Safety and Quality in Healthcare, for the closing address.
As Chair of the Australian Commission on Safety and Quality in Healthcare, I'd like to thank you all for joining us today. As we come to the end of this event, I'd like to reflect on the insights we have gained regarding the safe and appropriate use of medicines in an ageing population. The discussions demonstrated the challenges and opportunities before us, as well as exemplar work to improve the safe use of medicines. One of the key takeaways from this event is the recognition that polypharmacy is a major challenge and can increase the risk of harm from medicines. The fourth edition of the Commission's Australian Atlas of Healthcare Variation noted that about 2/3 of Australians aged 75 years and over took 5 or more medicines. Many strategies to address the burden of polypharmacy have been highlighted today, including comprehensive medication reviews, deprescribing unnecessary medications, and the use of tools to identify potentially inappropriate medications. There is a need for collective effort across the health system. Through collaboration and knowledge sharing, we can reduce medication-related harm. I am proud of the Commission's work in medication safety and digital health, which is critical to the safe use of electronic medication management systems. In closing, I would like to express my gratitude to all the speakers, panellists, participants, and support staff who have made this event a resounding success. Thank you, and I look forward to witnessing the positive impact we can collectively achieve for the safe and high-quality use of medicines for all.
Thanks so much, Christine, and thank you to all our speakers today and to all of you for taking the time to listen and learn. Thanks especially to everyone who submitted questions. We did get to as many of them as we could. Do keep an eye on your email and on the Commission website, where more information will be coming through in the next few days and weeks. Keep the conversation about appropriate use of medicines in an ageing population going to ensure that people receive safe care. Have a great evening. See you next time.